Hey, that was us.
How are you?
I have a bone to pick with you.
Oh boy.
You didn't reach out to me on Monday.
Was it your birthday?
No, that's May 26th. I'm a Gemini.
Okay, let me write that down. What
Liz,
happened Monday?
Monday was Greek Independence Day. And
Oh,
you know I am the ambassador of all things Greek. And you didn't reach out to congratulate me on Greek Independence Day.
that is awful. I'm so bad. You're right, Chris. I should have known that might be bigger than your birthday.
It is. And I also need to celebrate it because I'm sad that my sister, who's having twins in like 3 weeks, will not name her kids a Greek name. And I am absolutely upset about this. So
Why won't she?
she thinks that the Greek names are kind of lame. She's looking at a certain name that has an origin in Greek. So I'm pushing for that one heavy. But yeah.
Selena, I need to talk to her.
I know, it's almost as if she can name her own child. How dare she think that's possible?
Doesn't make any sense. Like, I guess,
How did you come up with the names for your kids?
Okay, guys, I didn't find out gender. So we actually didn't have names even going into the hospital for boy or girl for either girls. And so it was so funny with the second, we literally took a dry erase marker to the window of the hospital and did trees to try to figure out names. But we went with family or biblical was my big thing that I kind of wanted to stay within. But it's hard. Names are hard. They have those. Yeah. That's you talk about OCD. You're we're always worried something's going to last forever. It's someone's name is their name,
I know, it's crazy. And then it's funny because every name that's been thrown out, people are like, okay, can kids tease you with that name? Is it, is it awkward? Is it weird? Does it work all stages of your life?
Name, that's always a question. What are people going to actually call them if that's their name? Do I like that? It's just, it's a lot.
It's a lot of work. I know with OCD, man, making decisions, obviously better with treatment. I don't know how I would have done it at the height of my OCD. I would have probably been changing the baby's name up until it knew better. So, but how are you doing?
I'm good. I was just this morning, oh my gosh, it's just me and Chris. I'm so excited. Chris, Trondsen, and Liz are back. It's just, I feel like it's been a long time since we've been able to do a true, just ask the experts, just chatting, giving feedback. And we've had so many good talks and so much content and so many experts lately that I'm excited for today. How about you?
Same. It was funny when I was looking, I was like, oh, it's just Liz and I. Oh, gee. I love, as you know, we love having our guests and we love bringing people new perspectives and new clinicians. And sometimes it's just what's cool about this is we just seem to get through more questions. But, you and I know that we have this mountain piled of back end questions, but live questions as well. So excited to be here and just us two. It's cool.
Yes. Okay, so I want to start. I want you to just share some insights around recent talks and what resonated the most with you, some things that you really loved, some things you want, all the above, but would love to just hear some thoughts.
Yeah, no, it was great having Sanj on. I think that for a lot of people, medication is part of their treatment experience. And so medication is scary for a lot of people. I think it's scary because there's societal stigma and there's unknowns. So having Dr. Saxena on was great, just really getting some of those perspectives. We had, it wasn't super recent, but we had Stephanie Woodrow on and we talked about, depression and co-occurring depression. And I think a lot of people with OCD experience that. The DSM talks about 63% of people with OCD have a depressive disorder. So I hope people go back to that stream. Just to really, really kind of learn that depression is part of the treatment. And if you're not addressing it, it may negatively impact your treatment. And then obviously the one we just did recently with Marisa Maza and John Hirschfield, who are great friends of the show, and just talking about how ERP can be so life-changing and life-saving and not have trying to get away from the negative stigma it has. So yeah, those were great. Obviously, the core fear one keeps doing really well with our good friend Michelle Massey, and I think core fear work is so important. And then lastly, Michael Heaton and the talk on inhibitory learning was for both of us was a crash course. It was great. So I hope people go to our YouTube channel, the IOCDFs, and click under live and watch some of these back for sure.
Yeah, no, I totally agree. And I think that I loved all of the above. I think obviously medication ones are always really helpful. And I really loved having John and others on. And I feel like what has kind of happened is I feel like we've come back to this place of this clear understanding of like, how do we know where to start and what does the evidence and research show us? And it continues to tell us that ERP is where you start. With medication, SRIs are where you start, right? That there's this like clear understanding of here's where you should start. And then we can start to think about what makes sense next and what the different options are. But this is where you start. So I feel like sometimes I need that reminder of like slow down and like get back to the basics and make, like, you think about it like math, like you can't do calculus if you don't have a good basic understanding of algebra, right? And so it's like, how do we make sure that things are building upon each other? That, you know, a lot of folks talk about like once they started integrating ACT or they started integrating some DBT skills, how useful that was for them, but also they had a sound foundation of ERP first, you know? And so I really appreciate that reminder, because y'all know I'm all about like, what's new, what's happening? Like I always love to like move fast and learn and grow, but then it's like, okay, but this isn't, I don't want any patient to feel like they're showing up as a trial and error as a guinea pig, right? But that they're showing up doing like what we know has the most evidence and research behind it.
Yeah, one thing I always want to put out there, both to clinicians that are watching this and people with lived experiences, Liz and I obviously are not against other interventions. That's why we've had people come on, and there's been live streams in the past about different interventions. Obviously, Marisa talks a lot about ACT, for instance. We've brought up DBT as part of a supportive treatment plan. What we're just always saying is, you know, I think of it like for me, I'm going through some health stuff with my sleeping. I have obstructive sleep apnea and it causes a lot of difficulty with sleeping. And it's nice to know what the frontline stuff is. And I did look into like some alternatives, but everybody there was saying, look, if you're not doing the frontline stuff first, this stuff is like, only use it if everything else hasn't worked. So it's the same thing in our medical, you know, the medical space. You want to know like what medically shows to help all people. And if you try it and you put your all into it and you've done everything and it's not working, then obviously they talk about adjunct stuff. I think about what Sanj was saying about medications, right? Like SRIs is frontline, and some people might need to add Abilify or Wellbutrin or these other adjunct medications to really, really do well. So I think it's one of those things, is just reminding yourself that this is where you kind of start on your journey with specialists, and then make sure you're getting that right care. And then, you know, there might be some other things that are getting added in. So, you know, just following that kind of treatment plan, I think, is important.
Totally. Yeah. So, questions, you guys, remember, welcome. Hi, we're excited to have you. This is intended to be educational, not replace treatment or therapy, but instead we're really sharing our clinical and of course personal experience here on this platform, as the hopes that it will help provide some education, support, and information that you can go back and implement with your personal treatment team. IOCDF is not a crisis hotline. If you're feeling unsafe or suicidal, please call 988 or contact your local emergency services. Please submit questions that you guys have. You can put those in the right-hand pane, and we want to answer those. So as you have questions, we want to be able to answer them as they come up. Chris, I will let you start it off today with some questions. Do you want to pull from pre-submitted, or what makes sense?
Yeah, absolutely. Some people were asking real quick about Norwegian, because my sister are half Greek and half Norwegian. And actually my brother-in-law is Norwegian. So they're looking at Norwegian names instead of Greek ones. So yes, good pointing out, Amy. I don't want my Norwegian side to see this and be mad. I think this is a good question. This is a topic that we've talked about in the past, but we haven't talked about recently. You know, we always talk about, let me put the question in the back end for Amanda to put up. But the question is, can grief be part of OCD, and can it be all consuming, and how do you deal with grief that comes with OCD? I think it's a good question, because we always talk about anxiety and people hear anxiety, but people with OCD experience a whole range of emotions, including grief.
Yeah, no, this is a great question. And actually we get this a lot. We used to have like a grief and OCD group here at the clinic. And now we've kind of transitioned the name to be more about like life and recovery. But one of the things we've talked a lot about is, how do you process the grief that's kind of comes along with having severe OCD? So examples would be like, the things that we've lost, the things that OCD took away from us, the impact it had on our life. And also then how do we process kind of moving into like, okay, I don't have OCD necessarily as bad anymore and it's not consuming or taking up my life, but now I have to figure out how to reintegrate with life and like how to get back into living. And that transition can be very difficult as well, and very different, right? Because a lot of people think, well, if I didn't have OCD, everything would be great. And it's like, well, wait, now I have to rebuild my life that I have kind of neglected for the past 10, 15, 20, however many years. My OCD has been really significant in there. And so, I think that, of course, there's grief that's from loss that's different than grief from OCD. And many people can be dealing with loss, grief, and OCD, and those certainly can impact each other, trigger each other, increase vulnerabilities, and that OCD could really attach to it. But when we're talking about the grief that comes from OCD in the sense of like having this grief about having an OCD diagnosis or about what it's taken away from you, it is a little bit different than OCD alone, right? We're not going to treat grief with uncertainty, and we're not going to treat it with necessarily ERP, but instead it's about being able to process that. And so this is such a good question. I want us, Chris, to go back to the talk that we did with Michelle Massey about treating the whole client and not just OCD, because I think that this is something we should talk about for a second, which is that when somebody shows up in our office and they're sitting across from us, our job is not to just treat your OCD and like that's all we're focusing on and we can't talk about anything else. And I'll be honest, those of you that are clinicians listening, that's something I actually hear a lot. I hear a lot of clinicians talk about feeling like I'm supposed to only treat OCD and it's supposed to be super goal oriented and I have to like knock it out, and feeling uncomfortable when they have to pivot into talking about the patient's breakup or the patient didn't get into the college they want, or these things that are upsetting to the patient and we do need to be addressing with them, but that don't feel like it's OCD specific work. And the reality is that if you are a clinician, yes, you might be an OCD clinician because that's your specialty, but you're still a clinician first, right? You should be talking to that patient that's sitting across from you. And if they're sitting across from you dealing with their parents are going through a divorce and they're not going to be able to do ERP today because they just found that out and they're processing that, you can't be like, okay, but we have to do OCD work instead. Let's just pivot. It's like, wow, like this is really hard. Let's slow down and process that. So can you talk a little bit about, Chris, like what are the clinical skills people would use to process, to work through grief and things that can be secondary from their OCD diagnosis, or to process and work through something that comes up while they're in treatment that isn't OCD?
Yeah, no, I'm glad you're bringing this up. I think when we get trained, I mean, this is something that you and I have talked a lot about for clinicians, is like, obviously when we all get trained, we get trained very manualistic. People have to do that in trainings, but as you do this work, you start to learn and to grow as a clinician. And you'll notice that your client isn't just a set of symptoms of OCD. They may have grief that comes up from like a death in the family, or what I hear is a lot of people do grieve the time lost to the OCD. And so you have to make sure you treat that. So you are going to use a different set of skills. You wouldn't use ERP. Some people might not even want to use CBT. They might think it's too much of a cognition treatment to deal with something that's really impacting them emotionally. So the good thing is there's a lot of different treatment modalities that can help people with grief. I always really, really like Brene Brown's work. I think she is just an absolute genius and somebody that a lot of us look to when we talk about grief work. And so as a clinician, if I'm working with a client, they're going to have grief, and I want to honor that. I want to validate that grief that they're experiencing, because that's their real, a lot of times when you're in that grief, right? Sometimes the thought patterns are pretty extreme, right? Like, my life is over. I know for me personally, it was like, oh, what's the point? Now I'm this age and I missed all these years. So as a clinician, it's really helping validate that grief, letting them work through it, and then having them sort of land on their feet and say, okay, the past did go in the past. Let's look at the strengths that you had. You really got in recovery from a severe mental health condition. Let's look at your strengths. Let's look at what it took to get there, and how can you start to use those strengths to build a solid life for you right now and to move forward. And what I find is when clients start to build up the life that they want as they are in recovery from OCD, they do start to become proud of themselves and enjoying the life that they have. So when we talk about what Liz said, treating the whole client, I don't have a client terminate the treatment, unless they want to. Of course, I don't force them to stay, but until they're really in a solid place, their mood is solid, they have a lot of things going on for them, they're back connected with people. So that's an important part of the recovery. And I just want to validate everybody watching. It is okay to be sad, angry, disappointed, etc., when having a mental health condition. I don't hear you.
See what happens when I'm muted? But again, to just remember that like life happens, right? We're not allowed to like put life on pause when we do OCD treatment, you know, even if we're carving out dedicated time, right? A lot of our patients, as y'all know, like come here to get dedicated OCD treatment here at our clinic, but like life still happens, right? There might be a loss, there might be situation, there could be job changes, right, that happen. And if we just ignore that, we're not meeting you where you are, but also we're asking you to suppress your emotions. And when you think about OCD treatment, you guys, what we're trying to teach you is to walk into your fears, to allow space for them, to not suppress them, to not avoid them, because that makes them feel bigger, right? And that's what OCD has taught you your whole life. OCD has taught you, when you feel anxious, do a ritual to feel better. When you know that a situation is going to trigger you, avoid it. Where we're saying like, no, don't avoid. No, don't do rituals. Allow yourself to feel the feelings. Allow yourself to be in it. That has to apply outside of OCD too. If you're experiencing grief or loss or difficulties and I'm just like, oh, well, ignore that and do this, that's contradictory to, again, the bigger message we're trying to send you about OCD treatment. And so y'all hear me talking all the time, but like, treatment isn't really about what did you learn specifically in treatment for your current symptoms or triggers you were dealing with. Treatment's about what you learn overall. How do you generalize that knowledge? How do you apply it to other things if they come up that are OCD, but also other things that might come up that are life and that aren't OCD, but the treatment model is very applicable.
Yeah, no, exactly. One of the things I hear John Grayson say it a lot, that people after ERP treatment are almost like heroes because they can handle, the uncertainty around the corner. And one thing that my clients have said is that some of the ERP and CBT tools that they learned in treatment are extremely helpful for them outside of it. And so navigating what life looks like after recovery, it's going to feel a lot of unknowns. You're putting yourself back out there. And it's okay to not know exactly how the next stage of your life is going to go after recovery. But that's kind of exciting. I tell clients, like, let's get some spontaneity back into your life. So I do think that the tools that we learn in treatment can be applicable to life outside of treatment.
Yeah. And I also think that the thing to be kind of thoughtful about is when you find that OCD treatment is really starting to pivot and you're showing up to your patient's office, your clinician's office as the patient, and you're not really talking specifically about OCD anymore. It's like, hey, this happened this week or that happened. And maybe they're not big things, but like these are things that are happening. That's also a huge indicator. Like that's when I slow down and I'm like, wait a second, Chris, can we recognize that we just spent the last 30 minutes talking about your last 2 weeks and what happened and OCD hasn't been brought up? Like that's huge, right? That's an indicator that OCD is so much better, that like it's being better managed, that now these other things are what's triggering or hard for me. And we may need to pivot the work, or we may need to think about, okay, like you might be ready to start stepping down from treatment. So it always tells us a lot of important things. Next question, Chris, is can you cover avoidance and how this could be a compulsion on its own? Many professionals seem to miss this. And this, as we know, like such an important thing in the OCD treatment and OCD cycle.
Yeah, one big place that I see this in clients is like clients will come in and say, I have I've been looking up OCD on the internet and I found this term pure O, and I have pure O, like I only have obsessions, I don't have compulsions. And as we start to navigate through their signs and symptoms, one thing that they will put out there is that they avoid a lot, so if it's triggering to do something, they just won't do it, or they'll do it at times of the day where it's less triggering. And so they may not have overt compulsions because of that, but it's simply just because they're not putting them in situations that are difficult. So I'm like, okay, you do have compulsions. They're just not showing up right now because you're living a lifestyle of avoidance. So let's say I really, really am afraid to be around people. I'm afraid to get unknown illnesses. An avoidance would look like ordering everything on DoorDash or ordering everything grocery, like a grocery delivery service, so you don't have to be around people. Let's say you have hit and run OCD and you have a neighbor that works with you and goes to the job. So you drive in their car, you ask them to drive and you give them gas money. Let's say that traveling causes a lot of fear because of checking. You're always afraid you're leaving things behind or leaving the stove on before a trip. So you just don't take trips, or you have somebody watch your house to come in and check the stoves. You may not be doing compulsions overtly, but it's because you have replaced, you've sort of shifted your lifestyle, so you're less likely to have to do them. And so I always tell people, like, sometimes people do too much in compulsions, and the treatment is to pull back on your compulsions. So like wash less, pray less. But a lot of people's compulsions are avoidance. They just don't do things. So that's where the treatment really is let's sort of look at why you're having the avoidance. Like, what false beliefs are you sort of believing that OCD is reinforced over time? And then how can we challenge that behaviorally? So if you're driving a certain way to work, that's 20 extra minutes, so you don't go by a school because you have intrusive thoughts about hitting kids with your car. Let's work up to having you drive the opposite direction and go by the school to get to work, because it's values-based. It gets you there sooner. So that's the work that we have to do, is get you back engaged in life, things that are important, and dropping that avoidance.
100%. And I actually will say, I think sometimes this is like not research based, this is Liz based. So I want to disclaim that, but I am a big fan that, like, I'd actually rather you be engaging in activities and doing rituals than avoiding altogether, because now I've got two things that has to happen. I have to get you back to engaging in life. And then I have to remove the rituals that comes along with it versus removing the rituals. And what I say by the real reason this is important to me is that if at least you're still engaging in activities, I can push you of, like, we can use that as motivation of, like, okay, you want to do these activities, they're meaningful to you, they're important, let's get rid of the rituals so it can be enjoyable, versus when people are like, oh, well, I don't care if I ever go to the grocery store again. It doesn't bother me at all. And I'm like, oh boy, now I have to, like, convince you of why it's important to do this ERP and to not do these rituals, versus you already see the value in that because you've still been doing it. You just want to be able to do it freely. So I would say, like, avoidance is a really dangerous, slippery slope, right? And what we also know is that avoidance tends to then also come with isolation, which isolation breeds depression. And we've got a lot of secondary things that can pop up. Next question I want to cover, and it was asked by someone earlier. She was talking about how she sometimes gets stuck on, like, words and sayings being perfect. So the main question was, how can I stop rhyming without focusing on words? Scripts are hard for me. What other options can I do?
Yeah. So was there more context? So the way that I'm reading the question is,
the more context was, I deal with rumination over making words and sounds just right, mostly rhyming words. I've used opposite action as a tool I can use to help me do ERP. I'm finding it a bit complicated. How can I stop rhyming without focusing on the words? Scripts are hard.
Oh, okay. Sorry. I see the full question. That's helpful for me. Yeah. So anytime somebody has anything with just right. So the concept behind just right is typically when we talk to somebody about their core fear around just right, it's simply just they do not like the feeling. They don't like the sensation. It's not always associated with something bad might happen. It's often just like, if I don't do it this way, it makes me really uncomfortable. So in this case, what Terracotta is saying is, I ruminate over making words sound just right, mostly rhyming words. So what I would say first and foremost is, let's address the rumination. The rumination is about, it sounds like the incident happened or the incident is going to happen, and you're spending a lot of times in your head either focusing and replaying something that happened in the past, or you're focusing a lot on what can happen. And the way that OCD cons us into ruminating is it says, hey, this will help us. This will make us better prepared for this difficult situation. If you spend time kind of mapping it out, imagining the situation, how are you going to deal with it, et cetera. But what we really know, Terracotta, is that just increases our anxiety, kind of takes us out of the present moment, and just has us in our head, just kind of like spinning. So the first and foremost thing that I would work on is that rumination, and say, look, like, I'm going to be present and engaging in my life. And sure, something may have happened in the past or the future, but I'll deal with it when it arises. As for the actual, like, just right, once again, like I said, the lie that OCD tells us with just right is if I don't sit down just right, if I don't say a word just right, if I don't repeat it just right, I'm going to be anxious and then I can't focus and that anxiety will last forever. And that's the power of the treatment. It's almost like a behavioral experiment. Let's see if it really lasts forever. We know scientifically it can't. Anxiety fades over time. We just can't sustain an intense level of anxiety back to back for multiple hours. So let's test that out and dispel this rumor that OCD is going to have you last with anxious forever. As for the exposure itself, I always tell clients with just right OCD, we're going to start to do things just wrong. We're going to come up with ways to deliberately not rhyme or to mess things up or to break patterns that OCD wants you to have. And then what we're going to see is that outcome really as bad as OCD makes us? In that immediate moment, it will feel pretty intense. And that's where your power comes in. What is my relationship with my thoughts and feelings? Am I going to cave and do what OCD asks? Or am I going to learn to do things just wrong? Move forward and watch that anxiety fade and learn, hey, this fear that it's going to last forever is just not true.
Yeah. And what I would say again, just to add on, is to remember that the goal is not to just try to stop rhyming. Right. So again, I think about that a bit as like white knuckling, right? If it's like, oh, I just want to make sure, I just want to not ritualize. It's like, well, yes, we want to, of course, not ritualize. The only way we're going to do it is kind of just not do it and feel the anxiety. But it's also about being able to recognize, why do I want to ritualize? And am I addressing that core fear? So I'd encourage you to watch our core fear webinar as well, that you can find on IOCDF's YouTube channel, but it's so important that we're not just trying to like suppress or avoid or like grit our way through not doing a ritual, and instead that it's also about we're actually allowing space for discomfort. So like, how do we not do it? Well, like, first of all, yes, in the moment we don't rhyme, but we also do what we call planned ERP, where we're going to say, okay, like, I'm going to purposely say some words the wrong way, right? I'm going to say them really fast or really slow or ways that feel like it's not perfect and it doesn't fit my OCD's rules, whatever those are. And when that discomfort comes up of like, you said it wrong, and so this is going to happen or that's going to happen, whatever your core fear is, because I don't know, it's about being able to be like, like, yeah, that's what OCD is telling me, and I'm going to choose not to figure out if that's true. And we keep moving on, right? So we do planned exposures versus like every time you talk, you just try to not ritualize. It's like, I want you to purposely do it a little bit wrong, a little bit funny, a little bit off, to where you're going to evoke that anxiety and allow space for all those OCD thoughts and discomfort that comes up, and choose not to figure those out and move forward. That way, next time in the moment, you're not trying to just not ritualize. You actually won't have that trigger as much to ritualize.
Yeah, we had that conversation in our support group last night. The concept between, somebody was saying, look, like I'm doing what I'm supposed to do. And what the group members were asking them, yes, you're doing it in the moment, but how about outside of that? Like, do you have any kind of things scheduled in? Do you have plans? Are you putting aside some time? And the person was like, no, and admitted that in the past, when he did, he was doing a lot better with his OCD, to the point that he felt it was managed. So that's what Liz is saying, Terracotta, is just like, it can't be in the moment and a reactive. We got to be on the offensive.
100%. Next question is going to be for you, Chris, from Kylie. Oh, we're going to hop to Kylie's question at 11:23. I got better from BDD for about 8 to 9 months, and then I completely relapsed. How do I start getting better again when my BDD makes me believe I now look different?
Yeah. So Kylie, that's one of the things that BDD has the power to make everybody feel, is that they look different. In fact, sometimes when people are in a worst case, a really severe case of BDD, they get to a point where they feel like they look different throughout the day. Maybe they feel good in the morning in their home in comfortable lighting, and then they might go to a friend's house, or they might go out and then see a glimpse of themselves either in a picture or a mirror in a different set of lighting. Sometimes you're in a different mood state, etc. So we know that BDD can make people feel like they look different 3 to 4 times a day. So it definitely can make us feel like we look different 8 or 9 months later. Often it says, hey, like, your skin has gotten worse, or if it's more about body shape, like your body shape has changed, or, as you're getting older, your hairline is changing. Like, it's really good at keeping you constantly sucked in. I would say the first and foremost thing to remember is us with BDD, unfortunately, our left hemispheres are hyperactive, and our left hemispheres are responsible to ignore the whole picture and fixate on finite details. And then unfortunately, we back it up by getting real close in the mirror. We spend long periods of time. And remember, if I'm spending 15 to 20 minutes in the mirror this close, it's going to look distorted. Or if I start to avoid mirrors, I'm going to keep replaying this like distorted image of myself. So you want to recognize the tricks BDD uses to con you into thinking that your appearance has drastically changed 9 months later. And it's starting to look at like, what thought patterns are you having? Cognitive restructuring is an important part of BDD. So looking at your thoughts, how are you getting kind of sucked in by the BDD? Are the all or nothing thoughts? Are you projecting your fears onto other people? And what things are you either avoiding or doing compulsively, like taking different pictures from different angles, etc.? When you start to shift how you're responding to the BDD, in addition, we know perceptual retraining is important. So making sure that you're looking at yourself in the mirror, arm's length difference, you're seeing your whole self, you're being objective with your language, and making sure that you're challenging the negative thoughts that are coming up. The good news is if you've been in a good spot with BDD before for 8 or 9 months, it's there. It's just louder. We know just like OCD, BDD ebbs and flows. So it's so important to really look at the tools that has worked for you for the last almost year and start to implement them slowly and starting to get back on track. We know that with this treatment, I think of it as like momentum. You'll get back to that place for sure. It's not about,
No, and the thing I always remind people, especially with OCD too, right, is that it's trying every trick it can to make you fall for it, right? So it's making you fall for the belief that it's different now, you look different now, right? That it's changed throughout the day, whatever it might be. And the more we can start to see that for what it is, which is like, this is BDD playing a trick on me. This is OCD playing a trick on me. Or like, this is OCD making me think a false alarm is real, right? Like the more we can have that engaging in that kind of cognitive diffusion, like being able to see and separate ourselves, like thoughts are not truth, is important too. And that's part of that. We did a webinar, what was it, Chris, about 3 weeks ago on BDD?
Yeah.
So you can go to the YouTube channel for IOCDF as well and find the BDD webinar. But we talked a lot about how with BDD, there is more cognitive therapy work that's done up front before we hop into ERP, because so many people are a little bit more fused with those thoughts than with OCD, right?
Well said. Yeah, please. Like I said to all of you, the good thing about YouTube is all of these live streams are under the live button. If you go to youtube.com/IOCDF, and Liz is right. We just did a webinar about 3 weeks ago. So it's a full hour of BDD content, Kylie, and it would be great for you to jump into that because it's going to answer a lot of your additional questions.
And can you give a little pitch about the upcoming conference?
Yeah, so the upcoming conference, as you all know, on July, it's the end of July this year, which is great in Orlando. We just had the BDD conference virtually on March 16th. It was amazing. We had 500 people show up, both clinicians and individuals with BDD. It was an incredible outcome. But the awesome thing is we have a BDD in-person track. So if you can make it to the July, I think it's like July 26th. I should have that date like memorized by now. But it's the end of July. If you can make it to our IOCDF in-person conference, the BDD Special Interest Group is having a whole day of talks and trainings for clinicians and people with BDD. So I don't know where you're at, but if you're close to Florida and can make the trip, or even if you're not close to Florida and really want to get a good solid day of BDD treatment, and it looks like the BDD I saw on the website, the BDD conference is coming back next year. So if you didn't make it this year, Kylie, please come back. It's virtual and you can enjoy it from the comfort of your home and hear from other people that have BDD and what worked for them.
You want to hop to the next question, or you want me to keep
Yes,
going?
I threw one in the private chat. So the next question would be, I like this one. How to determine which fears are rational and which are not. I'm taking medicines for OCD, but feeling scared about things like microplastics, PFOA chemicals feel rational to me. I think that's such a good question because a lot of times there are things out there that people are afraid of. How does someone with OCD navigate what is rational and what is starting to get into a compulsive space?
Yeah, I mean, I think, people always say, like, sometimes I don't know the difference, but what I find is that if I ask you really candidly and you're in a calm moment and I say, hey, if you didn't have OCD, what would you do? Most of us are able to say, well, I'd probably not care, or, oh, I might, actually get rid of some of these things, but not these other things in my house. Or, yeah, I know I'd get rid of these certain items, but I wouldn't go like obsessively check the rest of my items to think and see and make sure. And so I want you to be quiet with yourself about if you didn't have OCD or anxiety, what would you do? Or if someone else asked you this question, what might you tell them is a rational answer? And because I can't answer that, right? I don't worry about microplastics or PFOAs at all, never have. It's not something that triggers me. Even if I didn't have OCD, like that's just not something I spend my time worrying about. My sister actually, who, you know, is somebody that like does do a little bit more research on different stuff and is a little bit more, you know, into like, I'll give you all a quick example, but my sister gets very anxious about the fact that I don't like clean my fruit in the detailed ways she does. There's not a right or wrong. It's not her OCD. She's like, no, there's pesticides on your fruit. You need to clean it this certain way, Liz. And I'm like, I don't have the time. Like sometimes I wash it, sometimes I don't. I don't really care. And so my point is there's not a right or wrong. Hers is not driven by anxiety or OCD. Hers is driven by like, that's in her mind, like the way that it makes sense to do that. And from her research, that's what makes her feel comfortable. And so I think that there's this piece sometimes where we'll say, oh, it's all OCD or that's all anxiety, where it's like, no, actually, like people have the option in life to make their own preferences and choices, right? And to do things that make them feel comfortable in different ways, right? It rains a ton in Houston. I'm not afraid to drive in the rain at all. Some people might be like, not really comfortable driving right now in the middle of the storm. And so there's not necessarily a right or wrong, but it's like, what is your comfort level? What do you feel comfortable with versus not? And so again, the bigger thing I want you to think about is the decision I'm making or the decision I'm not making, because sometimes we're like, have analysis paralysis because of our anxiety, based on anxiety or based on me, right? If is this anxiety driven, like it feels urgent, I have to figure it out, it feels scary, it feels dangerous, it feels terrifying, or is it something that's like, oh, okay, like I think I'm going to do something different, right? So an example is like, somebody told me the other day that Stanley cups were found to have some lead in them. I don't know if it's true. I haven't even researched this, right? Or looked it up. I'm just telling you what I was told. And so if I go look it up and I find out that like, oh yeah, they do. And like people are recommending you don't drink them, I'm like, I'll probably get rid of my Stanley cups, but I'm not going to be anxious and triggered about the fact that I've already had Stanley cups. Me and my kids have already drinking out of them, because it's like, yeah, like nothing I can do. Right. And so again, and y'all can tell my anxiety is not driving that decision, because if it was, Chris, what would I have already done? I would have looked it up immediately. Yeah. Right? I would have been panicked about it, where I'm like, well, yeah, someone said that last.
And been like, is there anything I can detox from or something? Yeah.
What do I do? Was this dangerous? I need an answer. I need to know if I'm going to die. Like what's going to happen, right? Where I'm kind of like, oh yeah, I remember someone told me that. I haven't even looked that up yet. You can tell anxiety is not driving that decision, versus like, oh, what do you mean? Oh my gosh, I have to get rid of it. This is dangerous. This is scary. This is terrifying. When the reality is like, I already drank from it. Like probably it happened or it didn't happen at this point, and I'll make a decision moving forward about what I'm comfortable with. So again, what is the function of the behavior? If the function of like you looking into microplastics and PFOA chemicals is something that like you're interested in and you want to know, and that isn't something you want in your household, then like you should do that. And you should do that calmly and in a way that makes sense, and in a way that, you know, allows you to feel comfortable with the items you use in your household. But if it's driven by anxiety and stress and like these awful feelings, it's probably more of an anxiety fear.
Yeah, you nailed it. I mean, the only thing I'd add is I always talk to clients about the realm of normalcy. Like if this is pretty thorough and this is a lot less thorough in the center is kind of where people sort of fall. We don't want you in this extreme over here of OCD, and you don't have to go to this extreme where you're just not cautious at all and throwing caution to the wind, but find that realm of normalcy that you see friends and family. So I just run my fruit underwater for like, 30 seconds and call it a day. Some people don't rinse it at all, but some people are more thorough. I would say to the point where I've had clients that either never eat fruit, or they won't eat fruit out because they don't know how it's prepared, or they'll spend an hour cleaning their fruit. That's when it starts to get into those realms where it's becoming compulsive.
Totally. Yep. So again, what's the function, right? Is it because it's like, no, this is how I want to function and how I want to clean my fruit, or the function is I need to serve my anxiety and make sure I don't feel anxious at all about this? That one's more of a never ending loop. I love Terracotta's feedback that she said, thanks so much. And she said, I have not really tested out planned exposure. So I'm going to put that back into action ASAP. So I would say like, yes, yes, yes. I think so many people ask the question, here at our clinic, obviously we're residential in PHP. And so patients are doing about 4 hours of active ERP a day in addition to their other programming. And so the question I get all the time is like, what should ERP look like when I go home? And my answer is usually like, I actually don't really want you to worry about ERP when you get home. I just want you to worry about living your life. And if you're living your life however you want, you're going to be doing ERP, right? They're one and of the same, but we're going to look at it as you're living your life. You're not making any decisions for anxiety or OCD. But the exception I'll say is just that, what Terracotta just mentioned, is that if we find that certain things keep coming up or continue to be triggering, or that we keep getting stuck, we do need to implement some planned and active ERP. Because again, it allows you to just have that extra push of like, you're doing it more frequently, you're actually being proactive to it versus reactive and waiting until the trigger comes up. And sometimes you need to push that. So you kind of have to know for yourself, hey, I'm seeing that I can live my life and I can live my life freely, and that's amazing. Or like, hey, I'm living my life pretty freely, but I keep having a couple hangups around the same theme. I need to stop and do some active ERP for that thing to address it.
Well said. I wanted to really quick, I don't want him to think we didn't see the question, but I wanted to propose this to you, Liz, down the road. So Amanda, at 12:07 your time, Venkat asked, does the ketogenic diet work for OCD? Do you recommend it for patients? There's actually a talk that I did with a registered dietitian, a strength and conditioning coach, also an Olympic weightlifter, and a mindfulness and yoga instructor. And one of the things that came up was about diet. So what I was thinking, instead of us answering it, Liz and I, as not registered dietitians, we could propose that, doing that talk as one of the live streams, and us doing it here. And we can talk and get into a little bit more depth about diet. I will say what came out of that conversation, what I took from the registered dietitian, is that with the keto diet and things like that, if it is something that gives you energy and it feels good, yes, that extra energy and feeling good can help with having the energy to combat and to do the treatment. But a keto diet itself is not going to shift or change thoughts. But there is a lot of research coming up about the mind and brain connection. And so a lot of times taking probiotics and things like that and working on your gut can be found helpful. But once again, I'd feel more comfortable answering that question with a registered dietitian on. So just like we bring on a psychiatrist, it'd be great to do that. So Venkat, we'll put that in and definitely look at that in the future.
Totally. Next question is, we have lots of different ones. I want to get to these first before we start doing some of the pre-submitted, but we got a question at 11:38. What do you think of Dr. Greenberg's approach to OCD? I have found lots of benefit with his approach to rumination, not sure of the psychoanalytic perspective.
Yeah, so to talk on the psychoanalytical perspective, if you look at his work, what he says is that often our core fear is from something from our past. So let's say you do, you're looking at your core fear, and maybe your core fear is like, I'll be abandoned. And then you look in your past history and you recognize that you were abandoned by a parent. Maybe they moved out of the house and started a new family, for instance. I'm just using a total generic example. He believes that's the psychoanalytical perspective, is that, hey, we got to really dig deep and work on that connection between like your hurt from the past and how it's correlated to your core fears. The one thing I do respect about Dr. Greenberg is he makes it really clear that this isn't an evidence-based practice. This is something that he's proposed and he's been doing with clients, but it's not evidence-based. So we don't have any research to back that. What I just find clinically is sometimes somebody's core fear is related to something they've experienced, but I've worked with clients that are atheists or agnostic who have a fear their kid might go to hell, yet they don't even believe in hell. So they don't really resonate with their core fear. They resonate with the anxiety it brings on. So that's why it's difficult, because some people do recognize that, some don't. Now, when he talks about his approach to rumination, I remember doing a panel with Kim Quinlan. We got asked the same question. A lot of us are already doing the work that he's talking about. I think people that are newly trained, what he talks about is when you are having an obsession, that obsession only lasts for like a minute or so, and then it turns into a compulsion. And a lot of times people mislabel their obsessing. They don't label it correctly as a compulsion. So for instance, if I wake up and I leave the house and I have the intrusive thought that, hey, maybe I left the stove on, that's the O in OCD. If all day I'm thinking about and replaying if I turn the stove off, that is not an obsession. That actually is now a compulsion. It just happens to be a mental compulsion. So you have to work on, tackling the rumination in that moment. What are you trying to solve? What are you trying to figure out? So what I would say is a lot of therapists already do that. I think his work is important to newer therapists that maybe never even talk about the mental compulsion part, or they treat obsessions as like lasting all day and say, just sit with the obsession. Let's work on only the behavior. So if you're interested, you could go to his website. Like I said, he makes it really clear that his work isn't evidence-based yet. It's just something that he's found helpful and what he's been putting out there for people.
Yeah. And again, what I want you to remember is that, again, what is the function of the behavior? If the function of the behavior is an irrational, intrusive thought that's just now because OCD has latched onto something, it's probably just OCD that we need to address now. But if it's rooted in a past event, trauma, right? So I'll give a good example, but there's been times where I've seen OCD that was diagnosed as OCD. People had called it OCD for 5 or 10 years. It looked like severe contamination OCD. And as that onion got peeled back, it was like, actually, there was a sexual trauma that was here. And these contamination rituals are actually trauma responses. So they're actually safety behaviors to trauma. They're not OCD. And in that case, we 100% have to stop treating it as OCD and do the trauma work. And yes, if there's still OCD left or attached, we need to pivot back. But at the end of the day, like, doing OCD treatment for something that's actually response to a trauma trigger isn't going to be useful. And so I want us to think a lot about, like I said, what is the function of the behavior? Is the behavior, like, OCD is unwanted intrusive thoughts. So OCD is often not rooted in a past event or something caused it, or there's something deep rooted we need to address. It's often an irrational thing that OCD latches onto. And so we don't actually need to do that exploration of the past. But if it is connected with a traumatic loss, with a traumatic event, with something that, really is this like deep rooted fear or thought, from our past, and in whatever different way that might be, sure, we might need to address that, of course, and then see if we also need to treat OCD. The second piece is that I think that a lot of folks talk a lot about like mental rituals and what those look like and how they're different. And it's just so important for us to understand that mental rituals are a compulsion, right? And that those need to be addressed the same way as do avoidance. And so making sure we're really thinking about that full OCD cycle. But we've done lots of webinars on comorbid diagnosis. And so I want us to think a lot about that. But if there's a comorbidity and another diagnosis, we have to be treating everything and figure out where to start and what treatment should look like. We talk about ERP. It is the most evidence-based intervention for OCD, 100%. That doesn't mean every person who has OCD should only do ERP, because you may have a comorbid condition that you need to do DBT as well. Maybe you need to actually do DBT first and then ERP. Maybe you have an active substance use disorder and that needs to be treated before you go do ERP, right? So again, every case is individualized.
Yeah, the only thing I'll add is if you're really interested, in Los Angeles on Tuesday, April 9th, there's a showing of a film called Pure O. And then Game Changers, Chrissy Hodges, and Dr. Greenberg are going to be doing the Q&A afterwards. So if you are in the LA area, you could go out.
Amazing.
And I think what I do respect about Dr. Greenberg's work as well is he doesn't say it's a replacement to ERP. It's in a way to use ERP to tackle rumination. So I think that that's an important caveat as well.
Yes. All the above. Love that there's always so many events. People are asking, is the virtual conference the one we're talking about?
So there was a virtual BDD conference. In fact, there's a lot of cool virtual conferences. There's a Faith and OCD conference coming up in April. The BDD one was Saturday, March 16th. We have the IOCDF's virtual conference, which will be in November of this year, I believe. But we definitely have the in-person conference is what we were talking about. There's going to be a BDD track, but there's also going to be a hoarding track, skin picking, hair pulling, and then the general OCD track. So that is every year in July for the IOCDF. And this year it's in the end of July in Orlando. So if you can make it out, it's about 2,000 people come out. It's an amazing conference if you can make it.
Amen. I hope you guys make it. They're also amazing. There's just so much content, so many different events, and it's so exciting. A lot of people are talking about hoping to see each other in Orlando. So I hope we get to see y'all there. We're really looking forward to it and are excited. All right, next question I want to hop to at 11:48 my time, 12:48 your time, Amanda. Question is, first complex trauma, so trauma therapy and then ERP, or vice versa? Great question, Chris. I'll let you take it.
Yeah, what we talk about whenever there's co-occurring disorders, because obviously complex trauma is something that we see with OCD. Sometimes there can be eating disorder, sometimes it can be severe depression. What I always talk to a client about is which is the one that is causing you the most immediate trouble right now, is a question. And then second, with trauma, complex trauma, sometimes people don't have the emotional regulation skills yet because they're just in their trauma. Let's say somebody is like, look, I'm finding myself having a lot of like either flashbacks or a lot of panic attacks, trouble sleeping. I personally would say, let's work on the trauma therapy first, if that's what's the loudest for you. And then let's integrate OCD treatment when you're ready, because ERP can be dysregulating. We can sometimes, when you're experiencing ERP, putting yourself in a situation that's triggering can sometimes have yourself really experience high anxiety. And if there's a correlation between that high anxiety and trauma, or if the situation like you were talking about, Liz, a second ago, where the compulsions are actually deep rooted in trauma, that can be disturbing and there's no learning happening, and then the ERP isn't going to work anyways. So I'll just use my own case. I dealt with some trauma growing up. I was diagnosed with that. But the OCD was dominant. And so it wasn't until the OCD was gone that I could even focus on the trauma therapy, because the OCD was so loud and so consistent that if I would have done it the other way, I wouldn't have even been able to pay attention. So that's the question I always ask people first. If they come to me and say, look, I'm experiencing both, which is the one that is dominating? Let's maybe start there. Or if not, maybe you could do it co-occurring. That is always a plan, either finding a therapist that treats both or having a treatment team, so seeing a clinician for each and having them collaborating. But the biggest question I ask people is like, ERP may trigger you, it may cause some dysregulation. Do you feel like you can handle it? And making sure that the OCD and the complex trauma isn't a mesh that the ERP is actually going to trigger the trauma.
Yeah, what we know and what our research would show us too is that oftentimes if trauma is unaddressed, we would want to do that first, because we don't want the OCD treatment, like Chris said, to re-traumatize the PTSD diagnosis. The second piece is to remember that ERP is not what we do for trauma, right? We don't do some uncertainty. So we don't do that uncertainty work for trauma, but we do it for OCD. And so, yeah, so it's all about kind of understanding, where am I? If I've treated the trauma, absolutely we should treat OCD, but can we do them together? Are they interrelated? Does it make sense to do them different? That's something you really want to seek guidance from your individual clinician on as well. Next question at 11:48 from Padima. What can a parent do when they're observing that OCD is very severe in their adult child? We get this all the time, and Chris, you've got some great resources.
Yeah. So first I'll tell you, I run a free virtual family and loved one support group every second Saturday of the month. Maybe Amanda could put it in the chat, but if you email info, so just info at OCD SoCal, that's SOCAL.org. Just let us know that you're interested in the virtual family and loved one support group. And we, second Saturday of the month, 11 to 1 Pacific Standard Time, we run a group. Liz has been on the group. Liz's family has been on the group. And it's just an awesome opportunity to hear from families that have navigated treatment and gotten better. Also, we have clinicians come on. We have different authors of OCD books. And then a lot of families are asking the same questions, so you get support on that. The difficulty is mainly if that adult child does not live with you. If they do live with you, then we can use the traditional kind of family accommodation measures, like a verbal or a written contract, working on reducing your accommodations and your enabling, etc. If your adult child doesn't live at the home, it's an additional challenge because there isn't really anything you can specifically do. So what I would see is, are they interested in learning more about OCD in a medium that they like? Are they watching YouTube videos? Do they listen to podcasts? So finding that for them and then passing it on to them, and then being open and honest about the things that you observe. What are some of the things that you feel like they could be navigating in life or enjoying that you see isn't working? So it's really just being loving, it's being supportive, making sure you have a relationship outside outside of the OCD, so they don't feel like every time the phone rings you're nagging them. But when you're together, just bringing up some of your observations, how the OCD is impacting them, but mainly how, would a live stream like this be supportive? A family group, hearing a story from somebody who's navigated OCD themselves. And a lot of times it's getting them to being open to potentially getting some help.
100%. Of course, the second piece, a lot of people are asking questions about books and book recommendations. I would also highly recommend The Space Book by Ellie Leibovitz if you're a parent. And it's great for both adult children, young children, but it's really about understanding how, as parents, you can start to set boundaries that will help your child get better or help them be willing to seek treatment. So it's a wonderful resource and tool in space. There are specific space providers who can work with the parents when the child isn't willing or ready to do treatment. So definitely look into that as well. I think we've gotten through most of the things. And so I want to end with, there was a couple questions and discussion around emetophobia. And so one person was asking in particular, do we think about emetophobia as being the same as OCD? How do we differentiate? Like, is it a phobia? Is it OCD? So do you want to just talk about that for a second? A couple of folks were saying like they didn't know what emetophobia is. So maybe you could give a little brief intro, Chris.
Yeah, so emetophobia is the fear of throwing up. So the fear of vomiting. A lot of times people will describe what's different about it. It's less of the fear. Some people do have the fear of the throw up itself, but the dominant core fear that I hear from clients that are experiencing it is just that loss of control, not knowing when it's coming, feeling out of control, out of your body, this thing happening. Sometimes people threw up when they were kids and really get triggered because it was such a embarrassing experience, etc. So what people often do is a lot of avoidance. So maybe they're not eating certain foods that they think that will make them throw up, not going on roller coasters or things that might make them dizzy. They might look if they have to take a medication or get a shot, seeing if the side effects have any kind of nausea or throwing up, and really creating a lifestyle that's different because of that fear. And we see very similar behaviors in OCD. What I would say is most of the clinicians that I know of treat it as OCD versus a phobia, because the OCD treatment, ERP specifically, often is being found to be much more advantageous than treating a specific phobia. So that's why often you'll hear or see emetophobia talks at OCD conferences, and most OCD therapists feel comfortable treating it. I've worked with very many emetophobia cases, and it's been very successful. And it's really working on, of course, reducing all the different compulsive behaviors, but also this idea of this fear of just being out of control and losing control. And what does that mean to them, and why does it trigger them, and why is it scary? And so really kind of getting to that core fear. And you're going to get sick of Liz and I saying core fear, but the reason is if you only focus the surface stuff, a lot of times when you uncover the deeper fears that are there, it can open up so much. One client, for emetophobia, it was just recognizing that, when he threw up when he was 10 and it was scary and it was frightening. Now as an adult, it's you can handle it. You're an adult. You would know what to do. At 10, it was frightening because you didn't know what to do. It was the first time. Felt embarrassed and scared. But now as an adult, you know what to expect. And so that fear, sure, is uncomfortable. Nobody likes to throw up. But, just how much energy he was putting towards it didn't, correspond with what really was happening and what he was really afraid of.
Absolutely. All of the above. Yeah. So it is 12:57. It's 11:57 my time, and I'm not good with time, and it's 9:57 Chris's time. But here we are. Y'all are from all over the world in different time zones. Good to see you guys. These always go so quick and we don't get to our pre-submitted. So I'm always like, we have to do some recordings of our pre-submitted, but I love these questions. It's so fun for us to come on and just be able to answer some of the specific questions that you guys have. But of course, our goal is that our other webinars are also addressing content and education that you really want to have. So please remember to go to iocdf.org/peace of mind and let us know if there's specific content, talks, individuals. I saw somebody wants us to have Jeffrey Schwartz on, people put that there so that we can see what we can do to get those guests on, to get those topics covered and go from there. But I just love being together. And Chris, I'll let you wrap it up.
Yeah, I just want to say, as always, especially it was fun just being with Liz today because it's been a while. And I just want to say, like, I always think of it as three of us on the panel, obviously us two, but you in the chat. Beyond just you all supporting each other, I just get so geeked out that you guys all have a community to come to every Wednesday, but also answering questions and asking questions to help us make this as successful. And then the only thing I'll say is don't forget to be back here next Wednesday with us. We're going to have a great talk on utilizing DBT, also the combination of BPD, borderline personality disorder, and OCD. We're going to have some great guests. We have Lauren Wadsworth and another guest who I'm forgetting off the top of my head, but super excited to have them. So we'll be back next Wednesday, same time, 9 on my coast and 12 on the East Coast.
Yeah, so next week we're going to specifically talk about BPD and OCD. So we're going to talk a lot about dialectical behavioral therapy and OCD treatment, which is ERP, how you integrate both, what you need to think about, what can be useful, what can't. It'll be a really important one. We get lots of questions on dialectical behavioral therapy and borderline personality disorder and when they're comorbid, what treatment looks like. But then also if people struggle with emotion regulation and need some DBT resources before ERP, what that should actually look like. They run a center where they have a dual IOP doing DBT and ERP work. So they're the experts. They're going to be here. Super excited to host them and to have them next week. And we'll see y'all here. Thanks, you guys.
Bye. Take care, everyone.